Bismillahirrahmanirrahim. My name is Wadali, Assistant Professor at Department of Pharmacy, Clark University of Science and Technology. Welcome to the course Pharmaceutical Clinical Pharmacy. Today, the topic of discussion is rabies. Outlines. We will discuss the following content one by one, like description, standard care of rabies, treatment, lecture outcomes. After watching and listening this, student will know about the rabies, standard care and treatment. Case study. Like PJ, a 14-year-old boy present to the ED 3 hours after being bitten on the leg by a neighbor's dog. He has a lacerations 14 centimeter long on his medial curve. Four distinct puncture marks suggestive of the teeth mark also are present on the curve. There is no suggestion of bone injury. PJ was healthy before the attack and has no chronic illness. Should PJ receive any treatment other than suturing of his laceration? This is the case study of the patient with PJ, 14-year-old boy, bitten by on the leg by a neighbor's dog. This is like PJ. This is the dog biting. Description: animals have different oral flora. Like animals have different oral flora, which alter the potential pathogen associated with the bites. Different oral flora, which alter the potential pathogen associated with the bite. The most common pathogen in dog bites are beta hemolytic streptococci, cephalococci, Pastorella maltosida, anaerobic bacteria, particularly bactericide species, Fusobacterium species. These are the normal, different, most commonly pathogen in the dog bites. Standard care. The standard of the care for all bite involves copious irrigation of the wound. PJ wound should be evaluated for deep tissue injury, devascularization of any tissue, or bone injury. The, the patient should be like PJ should be evaluated for this different the deep tissue injury, devascularization, and bone injury. Loose suturing or closure with adhesive strip is appropriate for laceration after irrigation. Like loose suturing or closure with adhesive strip is appropriate for laceration after irrigation. Although the antibiotic treatment is not required for some dog bites, the patient should receive a course of antibiotic. If the wound involves the hand or is near joint, like if near the hand or near the joint, if then they require course of antibiotic. If a patient, if it involves the deep punctures or is difficult to irrigate, then it requires the course of antibiotic. If the patient is immunocompromised like diabetic and splenotomy, so then they require the course of antibiotic. If the wound is not well perfused, then they also require the course of antibiotic. Prophylaxis for rabies. Like prophylaxis for rabies is required only if the animal is from an area with endemic rabies, or if the bite was the result of unprovoked attack by the wild animals. So then we use prophylactically rabies, like vaccination for the rabies. So then we use prophylaxis for rabies only if the animal is from the area with an endemic rabies, if the bite was the result of unprovoked attack by the wild animal. The local health board should be contacted to determine the recent rabies risk in that area. So the local health consultant should be there, and the local doctor should be consulted for to know about the rabies endemic in this area. Patient evaluation. If the PG has not received a tetanus toxoid booster within the past 5 years, a booster should be administered. The anti-tetanus toxoid booster should be administered if it is not administered from the past 5 years. If PG have never been immunized for tetanus, tetanus immune globulin should be administered in addition to the tetanus toxoid. Okay. The Advisory Committee on Immunization Practices recommends administration of tetanus vaccine and tetanus immune globulin as a part of the standard wound management to prevent the tetanus. So the Advisory Committee on Immunization Practices recommend the administration of the tetanus vaccine and the tetanus immune globulin as a part of the standard wound care management to prevent the tetanus. When treating a wounded patient, first attempt to determine whether a patient was complicated, the three-dose primary tetanus vaccination series. The patient has completed the three-dose primary tetanus vaccination series. If the patient immunization is unknown at the time of injury, the patient can be given tetanus immune globulin in conjugation with tetanus vaccine can prevent a tetanus infection. Like one should know about the to determine whether the patient has completed in the tetanus vaccination series before or not. If the patient immunization status is unknown at the time of the time of the injury, the patient can be given tetanus immune globulin in conjugation with the tetanus vaccine can prevent the tetanus infection. Case study. Because the PG has several punctures that have difficult to irrigate, he is a candidate for antibiotic therapy. Which antibiotic should receive? Although P. Coccidea often is considered the primary pathogen of the dog bite, antibiotic coverage also must address the other common pathogens. The selection of the appropriate antibiotic based on the most likely the pathogen from the specific animal bite. Most commonly, the P. multocida is commonly a primary pathogen of the dog bite. So, a monotherapy with an amoxicillin flavonate 500 to 875 milligram orally every 25 hours or every 12 hours is recommended. If the patient is allergic to the penicillin, tetracycline or doxycycline provide an adequate coverage. Doxycycline is preferred over tetracycline because most convenient to administer BD for doxycycline versus PUID for tetracycline. Can be used in patients with a decreased renal function. Must be taken with food. May be taken with food only slightly more expensive in the generic form than the tetracycline. If the penicillin-allergic patient cannot take doxycycline, a fluoroquinolone such as moxifloxacin 400 mg orally daily could be administered. Caution: in all cases, patient could be instructed to watch for improvement. If the wound does not heal or it worsens within 48 hours, the patient need to be re-evaluated. Antibiotic treatment should not extend beyond 5 days unless the signs of infection remains. Antibiotic treatment should not extend beyond the 5 days unless the sign of the infection remains. So this is the case, like for example the treatment in this case PG should be administer have a course of antibiotic. First we will prefer amoxicillin fluconate, and if the patient is resistant, like PG is resistant toward the penicillin, then we will give tetracycline and doxycycline. In this case, doxycycline will be preferred or tetracycline because of the reasons they are more convenient to administer, like mostly BID twice a day, while the tetracycline are administered 4 times a day. They have also be used in patients with decreasing immune function, may be used with the food. They have only slightly more expensive than the tetracycline. But if the doxycycline we cannot give doxycycline to the penicillin allergic patient, then we give the fluoroquinolone, such as moxifloxacin. In all cases, patient should be watched for the improvement. If the wound do not heal, it worsen within 40, or the patient need to be re-evaluated. Antibiotic treatment should not extend beyond 5 days unless a sign of the infection remain. If the patient present with an established infection, if the patient present with an established, parental therapy is warranted. If the patient is or if the infection is over the joint, has a lymphatic spread, or involve the hand or the head, parental therapy is warranted. If the infection is over a joint or has a lymphatic spread, involves the hands or head. If the patient has not responded to the oral therapy, parental second generation cephalosporin such as cefoxitin 1 gram IV after every 6 hours. Third generation cephalosporin such as ceftriaxone 1 gram IV every 8 hours have activity against P. multocida, streptococci, staphylococcus, and anaerobes. So, in case of the parental second generation cephalosporin such as cefoxitin, or third generation cephalosporin such as ceftriaxone IV after antidote are recommended in this case. If the anaerobe infection is considered, the addition of metronidazole to the cephalosporin therapy may be warranted, may be used. Like metronidazole is a antiamoebic drug, but they are the most preferred or have activity against the anaerobe bacteria. That's why they are mostly recommended in the dental procedures. Treatment should continue for at least 7 days or until all clinical signs of infection has resolved. So they should be the treatment should be you continue for 7 days until all the clinical signs of the infection have been resolved. Rabies vaccine and immunoglobulin. Rabies vaccine is administered for pre or post exposure prophylaxis. Rabies immunoglobulin is administered as a part of post exposure prophylaxis regime. So these are the vaccines, like they are administered for pre or post exposure prophylaxis, or rabies immune globulin is administered as a part of post exposure prophylaxis regime. So, rabies pre-exposure prophylaxis schedule, United States guidelines, like type of vaccination: primary, intramuscular, human diploid cell vaccine (DCV) or purified chick embryo cell vaccine (PCECV), 1 ml deltoid area, 1 each on day like 0, 7, and 21 and 14. Booster in second one is the booster vec type intramuscular like HDCV, PCECV, 1 ml at day 0 only. So day 0 is the day of the first dose of vaccination is administered. Person in the continuous risk category should have a serum sample tested for rabies virus neutralizing antibody every 6 months, and a person in the frequent risk category should be tested every 2 years. An intramuscular booster dose of vaccine should be administered if the serum titer falls to maintain a value of at a test at least complete the neutralization at 1.5 serum dilution by a rapid fluorescent focus inhibition test. So this is the rabies post-exposure United States guidelines. Vaccination category: not previously vaccinated, biological or IV and vaccine. Like total dose is 20 units per body weight. As much of the full dose as feasible should be infiltrated down the wound, and any remaining given through IM intramuscular. Human diploid cell vaccine or purified chick embryo cell vaccine (PCBCV) 1 ml, 1 each on day 0, 3, 7, and 14. Previously vaccinated: if the patient not previously vaccinated, if the patient has previously vaccinated, RIG not indicated, vaccine HCV and PCEC 1 ml, 1 each on day 0 and on day 3 only. Rabies immune globulin for a person with immunosuppression. Rabies post-exposure prophylaxis should be administered using all 5 doses of the vaccine on the if the person with immunosuppressive, if the patient is immunosuppressive, rabies post-exposure prophylaxis should be administered using all 5 doses of vaccine on day 0, 3, 7, 14, and 14 and 28 days. This is the case of the patient, the immunocompromised patient. These are references for the camera, like the case study that taken from the Kodak camera John B. Thank you so much for watching. Thank you.